Alright, so we'll look at the effects of neoplasm on host and the effects of the host on neoplasms, for example, tumor immunity and spontaneous regression of tumors. So the mind maps will summarize everything for us as we try and brainstorm and bring back every memory or knowledge that we have about this. So the clinical effects of tumors, even the benign ones are very important cause of morbidity and mortality. And yeah, whether through systemic factors or local effects, for the systemic or metabolic effects to could lead to it. So with the local effects, whether pressure, ulceration, hemorrhage and infection, or even obstruction and rupture or infection could lead to deleterious effects and could also lead to morbidity and mortality. So with pressure atrophy, for example, in pituitary adenomas, could lead to blindness and hypopituitarism, raising intracranial pressure, loss of specialized cells and endocrine function, and invasion. You know, intractable pain if it invades the nerves and there's a rupture of even vessels or loss of anesthetics. For example, the plexiform neurofibroma. Um, yeah, all serious effects from tumors. So ulcerations to tumor, ulcerating through adjacent surfaces leads to hemorrhage. For example, in melanoma or hematuria or even in infections too. Okay, so obstruction of the hollow organs, ducts, valves, of course, will lead to loss of function. And distant metastatic effects like tumor deposits results in similar effect at distant sites. With the metabolic effects, you have cachexia, which is a syndrome of progressive catabolism of body fat and a lean body mass, which is seen in cancer patients associated with profound weakness, anorexia, and anemia. It's usually seen in disseminated um, cancer, but may be seen in localized carcinomas like lung cancer. And the cause is not from nutritional demands by the tumor, rather, soluble cytokines produced by the tumor or the host response to the tumor. For example, in tumor necrotin factor alpha, interleukin 1, interferon gamma could lead to that. And cachexia worsens by low food intake from the anorexia due to taste abnormalities and deranged central control of appetite, and increased expenditure of calories due to high BMR, despite the reduced food intake. So, unlike starvation with low BMR, the basal metabolic rate will equal loss of fat and muscles. That's starvation, fat loss, and muscle preservation due to a protein mobilizing factor or proteolysis induces factor from the tumors. And anemia is very common, usually moderate to severe, and is the type, the nomocytic nomochromic type, and is due to many factors: reduced erythropoietin, poor nutrition, increased red cell fragility, hemorrhage, and also with immunosuppression. It's also very common. It affects both the humoral and the cellular immunity too, and leads to infection. So hormone production, actually appropriate elaboration of hormones more common in benign tumors um, than in cancers. For example, insulin from the islet cells, tumors, fetal hypoglycemia, which could lead to mortality, and thyroid adenomas leading to thyrotoxicosis, and parathyroid adenomas leading to hyperparathyroidism, pheochromocytoma could lead to severe hypertension, and inappropriate elaboration of hormones too, like the paraneoplastic syndromes too. Good. Okay, so for paraneoplastic syndromes, there are a syndrome complexes form in the cancer that are not due to local or distant spread of tumor, nor due to the elaboration of tumor indigenous to the tissue of origin of the tumor. They are due to production of hormones by tumors of non-endocrine tissues, or hormones other than those expected for a tumor of glandular origin, and it occurs in about 10% of malignant cancers. So, importance of this clinical is that it may be the earliest manifestation of occult neoplasm, for example, in hypercalcemia, and may represent significant clinical problems and even be fatal, and may mimic metastatic disease and confound treatment. Importance of paraneoplastic syndromes is that it brings forth several endocrinopathies like ectopic hormone production in Cushing's syndrome. This in 50% is due to lung cancer, and hypercalcemia is most common in the paraneoplastic syndromes, usually due to osteolysis from cancer or production of calcemic substances, for example, in tumors of breast and lung, kidney, or ovary. So let's look at this: a syndrome, the tumors, and the substances or the chemicals involved. So inappropriate ADH. The tumor is usually it's small cell carcinoma, the lung, intracranial neoplasms too, and the chemicals or the substance involved that ADH, antidiuretic hormone, and atrial natriuretic hormone. And for hypoglycemia, the tumors could be fibrocarcinoma, sarcoma, fibrosarcoma, or hepatoma, hepatocellular carcinoma, which the substances involved here are insulin or insulin-like substances. And for polycythemia, in renal cell carcinoma and hepatoma and hepatocellular carcinoma, erythropoietin is involved here. For carcinoid syndrome, we're dealing with bronchial carcinoid tumor, pancreatic cancer, gastric cancer, and with that, serotonin, bradykinin, histamine are involved. For myasthenia gravis, bronchogenic carcinoma, okay, so myasthenia gravis, so that's bronchogenic carcinoma is involved with normally immunogenic, and acanthosis nigricans, gastric cancer, lung cancer, uterine cancer can be implicated over here, and immunologic epithelial growth factors are all involved here. For dermatomyositis, lung cancer and breast cancer are implicated here, and it's usually immunogenic. For venous thrombosis or Trousers sign, and then that one, pancreatic and CA or lung mucosal carcinomas are involved. The mucosa activate the clotting. For anemia, thymic tumors too are involved there, and the etiology is sometimes quite unknown, or substances involved there a bit. It's sometimes from some researchers are idiopathic. For nephrotic syndrome, we have various tumors who could lead to that, and the tumor antigens could induce that. And with advanced cancers, or non-bacterial thromboendocarditis could happen, and the substances involved are the increased procoagulants to the hypertrophic pulmonary osteoarthropathy with finger clubbing, or lung cancers are implicated over here, and the substances involved are usually idiopathic. Alright, so effects of neoplasms on hosts. The systemic effects, it could be cutaneous manifestations like acanthosis nigricans in about 75% adenocarcinomas, and also dermatomyositis and above 15% malignancies, and exfoliative dermatitis and lymphomas and leukemias, erythema, gyraitum, real pains, that's in carcinoma of the bronchus, for pigmentations in carcinomatosis, pruritus in lymphomas and some carcinomas, epizoster located in Hodgkin's and other lymphomas, acquired ichthyosis in lymphomas, necrolytic migratory erythema in glucagonomas, yeah, and also neuromuscular effects could occur, like myopathies and several carcinomas and lymphomas, myasthenia gravis and other myasthenic syndrome in oat cell carcinoma of the bronchus, and also thymomas, and with mixed neuropathy like syndrome we have carcinoma bronchus, stomach, breast, lymphoma, and myelomas too. And sensory neuropathy, you have carcinoma of the bronchus, autonomic neuropathy, dementia or psychosis, cerebellar degeneration, carcinoma of the bronchus is implicated over here. The ovary lymphomas to bring some degeneration to also effects of neoplasm on the host too. And PMLE, papovavirus is rare, but also in lymphomas too. These are some of the effects of neoplasm on the host. Inappropriate hormone production by tumor cells to lead to Cushing syndrome like ACTH, adrenocorticotropic hormone production in Cushing syndrome, of the oat cell carcinoma of the bronchus, thymoma, carcinoid tumors, medullary carcinoma of chymos too, and hyponatremia in ADH-like substance, oat cell carcinoma of the bronchus, hypoglycemia in insulin-like substance, mesothelioma, and also liver cell carcinoma, adrenal cortical carcinoma. The effects of neoplasms to others include inappropriate hormone production by tumor cells. You can think of hypercalcemia, polycythemia, and carcinoid syndrome. So for hypercalcemia, you have your prostaglandins and parathyroid hormone having some defects in something like squamous cell carcinoma of the bronchus, cervix, and also renal cell carcinoma, lymphomas, breast carcinoma. For polycythemia in hematopoietic production, renal carcinoma, uterine leiomyomas, liver carcinoma, and cerebellar hemangioblastoma too, and also nephroblastoma or Host-Tumor implicated over here. So carcinoid syndrome like Th5HT, like oat cell carcinoma of the bronchus, and medullary carcinoma of the thyroid. These are all effects of the neoplasm on the host. And inappropriate hormone production, apart from those examples I gave, gynecomastia, hypertension, hyperthyroidism, pigmentation to good result. So with gynecomastia, the human placental lactogenol HCG2 group is affected over here, and aplastic or squamous cell carcinoma of the bronchus could lead to gynecomastia, testicular tumors, hepatocellular carcinoma too, hypertension, excess renin production, nephroblastoma. For hyperthyroidism, tumor, thyroid-stimulating hormone-like substance, vinhydratidiform choriocarcinoma, or glioblastoma, malignant teratoma of the testes too. And with pigmentation, melanin stimulating hormone like with cell carcinoma of the bronchus too. So mainly through interaction with host immune cells. It could be that's the effect of the host on neoplasm. There could be tumor regression, for example, in neuroblastomas, malignant melanoma, regression of metastasis after removal of primary, and the evidence of immunological reaction in histology, like infiltration by lymphocytes, plasma cells, macrophages, which correlates with the prognosis, and granulomas in drained lymphoid nodes too shows that. So immune deficiency states and malignancy like ataxia, telangiectasia, Wiskov, Aldrich, Chediak, Higashi syndromes, and also iatrogenic immunosuppression, lymphomas provides an indirect evidence of cancer immunosurveillance. Yeah, so evidence of immunological reaction, like rejection of tumor by animal hosts in several experiments that has been done. So animal models show CMI controls tumor growth, and the tumor associated transplantation antigens like the TATA is separate from histo compatibility antigens, especially irradiation and chemical induced tumors. Virally induced tumors produce TATs or the tumor associated transplantation antigens, which is different from the viral structural proteins. And also all these are evidences. Spontaneous tumors, whether animal or human, there are less antigens produced, and some neoplasms elicit CMI, for example, in malignant melanomas, renal carcinomas, and astrocytomas too. Alright, so the possible mechanism of immune tumor cytotoxicity in animal models is by, say, the FC receptor, FC antigen, immunoglobulin, the tumor antigens, there's like two toxic T cell and natural T cells, like the activation of the cellular arm and activated macrophages all play a role in destruction of the tumor cells. With spontaneous regression, there is shrinkage of the neoplasm that may or may not lead to total disappearance. It may be temporary, it may occur without therapy, which is spontaneous and has been observed in medical practice and in the lab too. So series of 176 regressions published between 1900 and 1966. There's even for renal cell carcinomas, neuroblastoma, melanoma, choriocarcinoma, carcinoma of the bladder. In 41 cases, metastasis regressed after resection of the primary tumor could occur. So with neuroblastoma in infants, it can change from malignant to benign, and a neuroblastoma or ganglioma, melanoma regression suggests an immunological mechanism. Melanoma is the spontaneous regression to occurring. Alright, so we continue with the next section soon.